next slide.
Sure. Hi everyone, welcome to our Thursday sessions for our Road to Final series. I'm Anna, I'm an F1 at Manchester Royal Infirmary. I've got Harry.
I'm F1 at Alfred.
And we'll be talking through MSK in orthopedics with you. So next slide, how it will work. I hope that some of you've been before to one of these sessions. We're changing things up a little bit for this one. Usually we would run through 15 MCQs and then talk through the answers at the end, giving you enough time to answer them in between. But we've been getting some feedback that can be understandably quite difficult to pay attention through the entire time, especially coming home from a long day of placement. So we've decided that we'll do 10 MCQs so we can keep it to an hour. And that we would do question, answer, and hopefully that will be better. At the end, we'll just give you some feedback forms to complete. And then if you could just let us know if you prefer that kind of format, that would be very, very helpful. So we've sort of the questions on common presentations as per the MLA content map. So it should align up really well with whatever curriculum that you've got based on your med school finals, because we know we've got people from all sorts of med schools here today. So should we just get started then? Next slide, please, Harry. So these are the MCQs. I'll give you a minute per question and I'll start polling now as well. So here we go. A 30-year-old female presents to the emergency department with sudden onset severe pain and swelling in her right knee. She denies any recent trauma but reports a mild fever for the past 2 days. On examination, her right knee is warm, erythematous, and significantly swollen. Range of motion is limited due to pain. Blood test results reveal a white blood cell of 13.4 and CRP of 85. Which of the following investigations would be most appropriate to confirm the diagnosis in this patient? I'll give you all a minute. Got one response so far. Can everyone see the poll? Okay. It's completely anonymous if that helps. Okay, that's a minute. Can we go to the next slide, please? So the answer is joint aspiration with synovial fluid analysis. Does anyone have an idea of what they think is going on? What they think the diagnosis is? Just put it in chat. Be brave. Okay, we're not sure or too shy to say. So we'll just move on then, next slide. So we'll talk through what this is: acute joint monoarthritis. So when you've got a red, hot and swollen joint and it's affecting one joint mono. Oh, perfect, we've got some answers through. So we're thinking septic arthritis maybe. So yeah, so this can be broadly split up into 3 categories. So either septic arthritis, which can obviously be bacterial, fungal, or even mycobacterial. Crystal arthropathies, so that's our gout, our pseudogout, and trauma can also cause a acute joint monoarthritis, as in hemarthrosis. So I'll just go through quickly each of these pathologies. So if we go to the next slide, we'll start off with let's start off with a focus history. So what kind of questions are we going to ask for people with acute joint monoarthritis. Would you mind just pulling up that Menti link, Harry? If you're able to. Let's follow the link.
I think I have to get on.
No, do I have to share?
Yeah, maybe.
Okay.
Otherwise, you can just do it in the chat otherwise.
Yeah, if it doesn't work. A lot of people might be just on their phones anyway. I've got it up here, so if anyone puts in a little word, then we can figure it out. So any ideas what we would ask in a focus history for something like an acute joint monoarthritis? So we've come here, we've got this lady who's come in, and she's got this hot swollen knee. What are we going to ask her? And to note, it's like a very common situation in OSCEs as well, because it's quite easy to ask questions about something like this. So I know I'm not sharing, but it says, I did get a submission in my word cloud. It says bilateral. So that's really important. Is it just affecting one joint or both joints? Or more than one joint? So should we do next slide? Other things we might want to ask, how soon did it come on? If we're thinking, if she's, for example, she's come in and she's it's developed overnight, that's much more likely to be something like gout, which quite often presents sort of that quickly. Any other joints involved? So yeah, this is someone else has put, bilateral. So it's extremely unlikely for it to be more than one joint in septic arthritis, as you can probably assume. And usually things like gout only affect one joint, but they can affect more than one joint in time. I think you'd have to be very unlikely to have septic arthritis in more than one joint at one time. So I would say it's impossible, but very near impossible. Recent trauma to the joint. So obviously trauma, we picked up that as a category for acute joint monoarthritis, and that can lead to hemarthrosis. But if you've also had recent trauma in terms of recent joint injection, if you've got osteoarthritis and you've been recently treated with a joint injection, you're potentially introducing bacteria into the joint, which can predispose it to something like septic arthritis. What goes along with that really is chronic joint inflammation, as in past medical history. So if you've got, for example, osteoarthritis or existing even gout, rheumatoid arthritis in that knee, that can also predispose you to septic arthritis. And as well as past medical history, obviously if you have a past medical history of gout, you're going to be thinking of gout. Renal disease also predisposes you to a uric acid accumulation, so that would also lean you towards gout maybe. A past medical history of IV drug use as well, that's significant for septic arthritis due to hematogenous spread. And bleeding disorders as well, that goes along with past medical history, so that would increase your risk of hemarthrosis, as in bleeding into the joint. And finally, sexual health history, which may not be the easiest thing to slide into a history, but it is important because it can lead to things like reactive arthritis and chlamydial infections that can lead to joint arthritis. Perfect. Let me just double check if we've got anything else here. Yeah, fever, so systemic upset is really important as well. You're more likely to have systemic upset in things like sepsis and pseudogout, not really seen in gout, to be honest. So we've got in this lady's history, what did we have? We had mild fever for the past 2 days. We had elevated inflammatory markers as well, including a raised white cell count. So both of those really lead us to believe that it could be septic arthritis, which is what people put in the chat, which I'm very happy to see. Could we move on to the next slide? So what kind of investigations are we going to do? Well, the question kind of pointed us that way, didn't it? I gave some, and the answer in this case was joint aspiration synovial fluid analysis. Now, we can split up investigations in terms of bedside labs and imaging. I'd encourage you to always approach your clinical scenarios like that, especially in OSCEs. So in terms of bedside, we can think of anything in the chat. Just pop in whatever you think would be relevant for investigations for an acute joint monoarthritis in the chat. This one's not as scary as a question because I gave you some options at the beginning. No? Okay, let's move on. Next slide. So obviously joint aspiration synovial fluid analysis, that's obviously the first one that comes to mind. And you should always do this before giving antibiotics. Another really important point here is when you're the F1, because you will be the F1 eventually, and you suspect a septic arthritis, it's very important, or even gout, it's very important never to do a joint aspiration of a prosthetic joint. So if they've ever had a knee replacement and their infection is in their knee, we're not going around sticking needles in that, because that can predispose to prosthetic infection, which can be life-threatening and very complicated to treat. Any joint aspiration to do with a prosthesis needs to be done in a sterile environment in theatre. You should definitely be calling the orthopedic surgeons. In terms of what you would see on the analysis, we've got a little white cell count here. So if it's absolutely raging with white cells, we know that's most likely going to be septic arthritis. Obviously, gout and pseudogout, they're still inflammatory responses, so you're going to have a raised white cell count. But it's less likely if the white cell count is under 500. In terms of investigations, really important to send off an FBC for inflammatory markers. These can signify whether there's any renal disease. CRP, obviously, to trend the inflammatory markers. Blood cultures, obviously, if we're suspecting septic arthritis. And baseline X-ray and ultrasound as well, if we can't get the aspirate off the first go. I know some people put X-ray for this question. It is important to get an X-ray in terms of a baseline investigation, but it won't help us confirm the diagnosis. So that's why synovial fluid analysis was the correct answer in this case. Okay, next slide, please. Yeah, so we talked a bit about septic arthritis already, and I mentioned the abnormal, damaged joint, prosthetic joints, any immunosuppression, and someone who is an IBDU. Causative organisms, so most common Staph aureus, strep group A, gram-negative bacilli, and gonococcal bacteria as well. In terms of treatment, we're just going to keep aspirating it until dry, slam them with some very strong broad-spectrum IV antibiotics until we get our sensitivities. We're going to give them enough analgesia, and that should do it. And we need to repeat our blood cultures after 48 hours to make sure that the infection is either gone or we're going the right direction. Next slide, please. So yeah, the other thing we need to think about is gout. So gout is a disease where there's too much uric acid in the blood, and that can either be through under secretion by the kidneys, but can also be due to overproduction because of inherited factors. Eating a diet rich in purines. It can also be found in tumor lysis syndrome and also psoriasis. Acute management, we really split it up into acute management and long-term management. So if someone comes to you, it's a first presentation of gout, we need to be giving them NSAIDs, we need to be giving them colchicine, and we can consider oral corticosteroids only if the above has failed. So that's your second line treatment. It's actually off license to treat gout. So long-term management, people get kind of confused about allopurinol. Now, if they've never been on allopurinol before, we don't start them during the acute flare. However, if they've had flares before and they're usually regularly on allopurinol, you just continue the allopurinol during the attack. And then this, in the fluid analysis, we're going to see needle-shaped crystals that are negatively bifringent. That means when you shine a light on it, parallel, it will turn yellow, and at 90 degrees, the crystals look blue, which is quite pretty, actually. And so that's gout. We can move on to pseudo-gout, which is next. And on synovial fluid analysis, we have rhomboid-shaped crystals, which are blue. Just also quite pretty, I don't know. Management is largely the same. The only difference here is that there isn't any specific treatment to prevent attacks like allopurinol. It's not going to work in this case. It's a calcium pyrophosphate deposition disease, which is sort of a calcium salt, and then that gets deposited into the cartilage. And then we can see that as chondrocalcinosis on X-ray, so bright white spots in the cartilage. Usually this is affecting the knee, but can affect the wrist, whereas gout usually classically affects the big toe. I think that's, is it pellagra? Is that what you call it? There's like an old-timey word for that. And is usually, pseudogout's usually associated with hyperparathyroidism or hemochromatosis. Cool. Next. So we've got question 2 now. So a 67-year-old woman attends the general practice for a follow-up blood test, which was requested by the orthogeriatricians following a distal radius fracture. The fracture occurred after the patient slipped and fell in the bathroom from standing height. She is otherwise well. And then list some blood test results for you to look through. And we're going to see what is the most likely diagnosis out of those 5. I'll give you a minute to answer, and I'll start that poll as well. Yeah, we should be able to send the slides out as well, and yeah, we'll send the feedback form towards the end of the session too. I don't have anything in my poll yet, guys. Thank you. Okay, I'll stop you there. So we're kind of torn between osteoporosis and Paget. Oh, I think osteoporosis just edged out there. So next slide will reveal the answer. It is indeed osteoporosis. So what are we going to look for here? So let's look at the calcium. Sorry, Harry. Calcium first, which is in normal range, which is good. The phosphate, which is about normal, higher end of normal, but still normal. Our ALP, again, higher end of normal, but still normal. Our parathyroid hormone, which is normal. And our urea slightly raised, or creatinine slightly raised. So we could say this is largely a normal blood test result. And we've just got mild renal dysfunction. So why is that osteoporosis? Well, let's go through the basic metabolic bone diseases. Next slide, please, Harry. So I've done this because someone specifically requested for me to go through metabolic bone disorders, which I'm happy to go through. So let's start with osteoporosis, which is just reduced bone mass and mineral density. And the risk factors are usually female sex. That's because as you age, estrogen is protective of bone mass. And when you age, your estrogen levels decrease, and that puts you at risk for osteoporosis. And it's associated with medications like corticosteroids, SSRIs, PPIs, antiepileptics, and some other hormonal drugs. The hallmark of osteoporosis on labs that you won't see anything. There's no biochemical changes that you can see. Osteopetrosis is a sort of dense brittle bone disease. It's due to a failure of normal bone resorption because of a defective osteoclasts. So we've got our osteoclasts, which are bone breaking cells, and osteoblasts, which are bone building cells. So because we've got defective osteoclasts, they basically break down all the bone, and then the osteoblasts sort of build it back up, but it's all done in a very chaotic way. So that's why we get overgrowth of cortical bone, which fills the marrow space. So usually we've got nice spongy trabecular bone in the bone cortex, but that's actually gets filled in with the cortical bone, the bone on the outside. So what this can result in is things like cranial nerve impingement, if you think about it, because of narrowed foramina in the skull. So you can get all sorts of, third nerve palsies, fifth nerve palsies as a result of this disease. And it can lead to, in severe diseases, it says right there, calcium deficiency. The next one is Paget disease, which is similar, but serum calcium, phosphorus, and parathyroid hormones levels are normal. There's sort of a mosaic pattern of woven and lamellar bone, and you can get long bone chalk stick fractures, and it increases your risk of osteosarcoma as well. Then we've got these diseases as a result of hyperparathyroidism. So that's, sorry, 1 second. So if we got primary hyperparathyroidism, we've got an abnormal overproduction of parathyroid hormone. So that raises our parathyroid hormone, which raises our serum calcium and lowers serum phosphate. And that can result in symptoms like bone pain, but can also lead to pathological fractures. Secondary hyperparathyroidism is elevated in a sort of like compensatory mechanism for low calcium and chronic kidney disease. And low calcium happens in CKD because of poor excretion of phosphate and reduced production of vitamin D. So that's why we need to oversecrete our parathyroid hormone, so that we can absorb more calcium. But that can obviously result in decreased bone mass and cause pathological fractures as well. Next slide. Yeah, so this is, we'll just quickly go over osteoporosis, which is, as I said, reduced bone mass and mineral density, and I went through the risk factors there. Next slide. We need to assess the risk in osteoporosis as well, and we can do that by assessing the 10-year fracture probability. We can do that with either the Q fracture risk score or the FRAX score. So NICE would recommend you calculate the FRAX risk score in any woman over 65 and any men over 75, but you could obviously do that in younger patients if they've got the aforementioned risk factors. We would then, according to their FRAX score, if they're intermediate risk or high risk, go on to measure their bone mineral density, and we do that with something called a DEXA scan. And a DEXA scan, we can calculate the T score and the Z score. So next slide. The T score is the number of standard deviations the patient's bone density is from the mean bone density of a 30-year-old adult, whereas the Z score is age and gender control, matched control. So, but we actually use the T score to assess whether someone needs to be on medical treatment with bisphosphonates. So this is the interpretation of the T-score, which is useful because it often comes up in those MCQs. So anyone with a T-score of below -2.5 should really be started on medical management with oral bisphosphonates. The initial length of treatment usually, could we press next actually? Sorry, I think I've got the slide on, yeah, osteoporosis management. Well, we obviously always start with conservative. So conservative management for osteoporosis is regular exercise. So you need to counsel your patients that you know you shouldn't stop doing whatever you were doing. It's actually really important to continue exercise because that strengthens your bones. Specifically weight training exercise, because swimming and cycling, things like that, they don't improve bone density. Stopping smoking is a big one. Reducing alcohol intake, making sure you're eating enough, have enough calcium intake, and if not, you should be supplemented with calcium and vitamin D. And then, as I said, in those with severe osteoporosis with risk factors and T-score of less than -2.5, we should be starting bisphosphonates as well. So that's typically 5 years for oral bisphosphonates and 3 years for those receiving IV zoledronic acid. And the patient should be continually being reassessed during this therapy as well. Next slide, please. So we've got a next question. A 63-year-old female presents to the emergency department with unremitting lower back pain accompanied by shooting pains down the back of both legs. The pain, which started a few months ago, was intermittent at first and associated with her legs occasionally giving away. Her observations are as follows: 130/80, 99 beats per minute, rest rate of 16, temp of 36.8. On examination, there's reduced tone in lower limbs and ankle and knee reflexes cannot be listed. She has a past medical history of breast cancer treated with radiotherapy, type 2 diabetes, mellitus, and adhesive capsulitis. What is the most likely diagnosis? Okay, so we've got a lot of metastatic spinal cord compressions. We've got degenerative, a couple thinking A and a couple thinking Corda-Quina syndrome as well. So I feel like I was kind of mean with this question, I'm not going to lie, but I'll explain everything. The next slide, please. So it is actually Corda-Quina syndrome. So yeah, let's actually start with this. Let's go with red flag symptoms. We can try our Mentimeter again, and I can read them off. Or we could just type in the chat and I'll read them out. Whatever you'd like. I guess if you're shy, you can just do it on Mentimeter since I'm not showing it to anyone. So what do we hear in a back pain history that we think, oh, that doesn't sound right. Oh, let's get you sorted right now. Should we go back a slide? Should we pick out anything that's worrying from her history? No? Okay, so some things are standing out to me. So she's got unremitting lower back pain, so that's quite worrying. Any unremitting pain, to be honest, is a red flag symptom, whether it's affecting your back. Headache is obviously one that's worrying too. In a limb, unremitting pain, that's all quite bad, especially when it's severe pain. Bilateral sciatica, so sciatica is quite common, but bilaterals are not as common, so that's also sort of something I've picked up on in the history. And occasionally legs giving way, that doesn't sound great either, though that's what we call intermittent neurologic claudication. Anything affecting sort of your motor function of your nerves, that should also be raising a red flag in your head. And we've got hyperreflexia on examination as well, some lower motor neuron signs. The other thing is she's got a past medical history of breast cancer as well. So I know a lot of people, and that's probably what people have picked up on and put metastatic spinal cord compression, but I'll explain the difference between cauda equina syndrome and metastatic spinal cord compression as well. Could you do next slide, please? Yep, so I've sort of covered that all. So these are the conditions that we need to be thinking about when we're thinking red flag symptoms with back pain. So cauda equina, so it's typically, classically associated with your saddle anesthesia, urinary retention, incontinence, and bilateral neurological signs. Spinal stenosis, which is the intermittent neurological claudication that I brought up earlier. Ankylosing spondylitis is also an important condition to be picking up on early, as the earlier you pick it up, the better the outcome for the patient. So typically morning stiffness and nighttime pain are classically associated with ankylosing spondylitis. Spinal infection as well. So if they're systemically unwell or have a history of IV drug use, can be associated with things like discitis. And a spinal fracture, obviously unremitting pain that's relieved by lying down flat. We're thinking could be spinal fracture, and obviously any preceding trauma would help us point us in the right direction. Can we get the next slide, please? Thank you. So I was going to explain the sort of difference between cauda equina and metastatic spinal cord compression. So obviously we're thinking this could be a tumor that's pressing on the nerves in the back, but where exactly will lead us to the exact presentation. So cauda equina obviously is the bundle of roots at the bottom of the spine, the lumbosacral nerve roots, and it's called the cauda equina because supposedly it looks like a horse's tail. I don't really see that, but we can just take the anatomist's word for it. Because they're peripheral nerves, so they're not actually part of the CNS, it will cause a lower motor neuron pattern of weakness, which is what we saw in the question stem. She was hyperreflexive. She was hyperreflexive. She didn't have, she was areflexive as well. So that's pointing us towards cauda equina. We've also got something called conus medullaris syndrome as well. And that's when we've got you can see that's above the cauda equina. And that's if there's a mass pressing on the conus medullaris, you would classically get a mixture of upper and lower neuron signs. That's because that's where the spinal cord is turning into the peripheral nervous system. So depending on where exactly the lesion is, you could be, for example, areflexic at the ankle, but hyperreflexive at the knee, for example. It just depends because it's affecting the actual spinal cord. Metastatic cord compression is affecting the spinal cord, which we know is part of the central nervous system. So that means that it will cause upper motor neuron symptoms. So does anyone know any upper motor neuron symptoms that we can put in the chat? Yeah, we got hyperreflexia, hypertonia. Perfect. Yeah, spasticity. Important to note, really early on, it can present with more lower motor neuron signs, but as it progresses, they will, like in a stroke, progress to upper motor neuron signs and symptoms. But in this case, it was, yeah, again, extensive plantar reflex as well. Perfect. So there's different things. I mean, obviously in this case, we're thinking it could be due to malignancy, but there's a number of things that can cause compression of the nerves in the spine. So obviously malignancy is one, a primary tumor, metastatic tumors, lumbar stenosis, which is just narrowing of the spinal canal in the lumbar region, which could be due to things like osteoarthritis, spinal trauma, again from vertebral fractures, disc disease, so any herniation of the disc impinging on the nerves, that can cause a cauda equina, and sort of infections as well. So yeah, if you've got an abscess in the spine, an epidural hematoma as well, they can all cause these sort of syndromes that we've just talked about. Next slide, please. Oh, actually, just briefly, what we want to do in cauda equina syndrome, we need to do PR examination to assess their neurological function, a full neurological examination, but specifically you need to do a PR exam to test for anal sphincter tone and perianal sensation. You also need to do a post-void bladder scan, which will help you gather whether we've got any urinary retention as well, and all suspected cauda equina syndromes, you need to get an urgent MRI, and that's true of conus medullaris and also MSCC as well. And the definitive management would be surgical decompression. Next slide, please. Sorry, I'm taking up your time. We'll try and get through these next ones quicker. So we've got a 15-month-old girl who started to walk over the previous 6 weeks. However, her parents have noticed she's a waddling gait. Her 6-week check was normal. Observation of her gait shows a left-sided limp with apparent shortening of the leg. She was delivered by Vertex delivery at 38 weeks. She was born with a calcanea valgus foot deformity of her left foot, which was treated with gentle stretching. Which of the following statements about developmental dysphagia of the hip is false? Right, so we've got some C's, some D's, and some E's. So the answer is D. So it keeps the hips flexed and abducted, so away like that, and that just pops the knee hip joint back into place. X-ray is actually the preferred imaging modality in infants greater than 4.5 months, and that's just because of bone development. Next slide. So I'll just go through some quick pathologies, and hopefully, does anyone know what this is at all? This picture. So this is calcanea valgus deformity. That's just when the calcanea valgus, the ligaments are too tight, and that just usually self-resolves in the first few months of life, and is associated with developmental dysplasia of the hip. And you just need to passively stretch the ankle, and it just resolves by itself. Next. And this is talipes or club foot, which needs surgical correction in the first few months of life. Next slide. And this is flat foot or pes planus as well, which doesn't require usually doesn't require any surgery, can be corrected with splints and things. And then most importantly, we've got developmental dysplasia of the hip, which was what the question was about. We've got two diagnostic tests that we do to screen for developmental dysplasia of the hip. It's done actually at birth, so then usually the next day a doctor should come around and check the baby, and you get checked for developmental dysplasia of the hip, but also at the 6 to 8 week check, and we do these two tests. Next slide. Which is, sorry about this really creepy cartoon, but it just goes over both tests quite well. So we've got the Barlow test, which aims to dislocate the hip, and then the Ortolani test, which is like in the Pavlik harness, we flex and abduct the hips to relocate it, and you'll feel this like clunking sensation when you put the hips back into place. Next slide, please. So just quickly, the most common congenital musculoskeletal abnormalities. The developmental dysplasia of the hip is usually, as I said, just diagnosed in the screening tests. It can be bilateral, but can be unilateral. But when it's unilateral, you can see leg length inequality. And as the disease progresses, it should really be picked up at the 6 to 8 week check. But when it's not picked up, such as in the question stem, you can see a limp and then early onset arthritis. But I think Harry's got a question about limp as well coming up. Next slide. This is quite a difficult question. I don't know, just because of time, we could skip it and come back to the end if we've got time, I think.
Yeah.
Yeah, is that okay?
Yeah. Let me just
skip ahead. No. No spoilers.
Okay, so I'll try not to be too long. Let me know if there's any questions or anything. So, question 6. A 12-year-old obese boy is admitted to hospital with a limp. He reports pain in the right knee and hip with limited internal rotation. Bloods are all unremarkable. So, given the most likely diagnosis, what is the gold standard imaging modality to confirm the diagnosis? So we've got MRI hip, an AP view of the knee, an AP view of the hip, an AP and lateral view of the knee, and an AP and lateral view of the hip.
I'll let you know what Paul says.
Cool.
Looks like everyone's sticking with E.
Good stuff. Yeah, so it is the AP and lateral hip X-ray, and the reasoning behind that is basically as a general rule of thumb, in orthopedics especially, is you want two views to make sure that you don't miss a fracture or pathology or certain condition. And quite often these two views would be an AP view, an anterior posterior view, and a lateral view of the affected joint. In this case, it is a hip because this child has something called SUFI. So when we look at sort of the limping child or someone presenting with the limp, we can split it up into either painful or painless limp. And then there are a number of different causes. Your standard ones, such as trauma, infection, something called Perthes disease. We've got an unstable SUFI, which stands for slipped upper femoral epiphysis. We've got DDH, development dysplasia of the hip. We've got a leg length discrepancy, a stable SUFI, and also neurological functional causes. So the sort of main ones that you could get asked about in an exam, we've got SUFI first of all, slipped upper femoral epiphysis. So that's when you've got the epiphysis, which is the end of the bone, and the metaphysis, which is usually where the bone widens. That basically slips off the epiphysis at the level of the growth plate, which is where it's more commonly in children. You usually get pain in the hip and also the knee. It's more common in boys than it is in girls. It's most prominently in someone who's a teenager, and typically it's an overweight, hypergonadal boys. So if you ever see, from an exam point of view, an obese child coming in with a limp, your sort of alarm bell should be ringing for SUFI. It can also happen in girls. Usually these are tall, thin girls. In the past medical history, there may be associated endocrine disorders as well. And so if we look at the diagram here, we can see sort of a normal femoral epiphysis in the socket here, a normal growth plate, and the metaphysis where the bone widens at the femoral neck. And here you've got where you've got slippage of that. So you quite clearly see slippage here. And another thing you can notice, because quite often in x-rays, things like fractures, slippages, dislocations aren't always that obvious. It's very much about anatomical planes and anatomical lines. So we've got something here called Klein's line. And a normal Klein line is where you see this imaginary line which goes through the greater trochanter of the femur here, and it intersects through the epiphysis, through the femoral neck, and through the neck of the femoral head. Whereas when you've got slippage, you can see that the Klein line does not transect the femoral head here. So hopefully we can appreciate here, if we go from the greater trochanter, we transect the femoral head there, whereas in SUFI we can see we don't. And treatment is usually percutaneous pin fixations, so they would literally hammer in pins to hold the bone back in place. We've also got Perthes disease. Now, this quite simply is avascular necrosis of the femoral head, and the two main areas that you might see avascular necrosis, at least presenting in exams, would be your neck of femur and also your scaphoid in your hand. And the reason why that happens is because you've got limited blood supply to these areas. So what you've got in the femur is you've got these circumflex arteries, these arteries that wrap around the neck of femur. And when you get, for example, a hip fracture or trauma, you can have transection or interruption to this blood supply. And because we have what we call a one-way blood supply, so there's only blood going to the head of the femur in one direction. If this blood supply is interrupted, then we'll have no supply to the bone. And as a result, you get this necrosis of the femoral head, or bits of bone basically die. So people with Perthes disease, they're usually a bit younger, so in the first few years of life. Importantly, you'll have a very painful limp. You'll get a loss of abduction, so the limb moving away from the body, and a loss of internal rotation. You can get slight leg length discrepancies as well. It's a lot more prominent in males as well. Only 50%, in 15% does it present bilaterally, and most recover without treatment. At the moment, there isn't really a known cause. There's a few sort of related things, genetics and things like that, but there is no sort of known cause for Perth's disease. But usually it's conservative management does the trick, physiotherapy. I've seen early, it's usually self-limiting. And then we've got DDH, which Anna's already gone over, so I'll skip over that just in the interests of time. So question 7. So we've got a 30-year-old lady presenting to eye casualty with blurry vision that started when she woke up. She's got past medical history of rheumatoid, and she takes methotrexate. So on examination, her left eye is red, and she's got severe photophobia. Slit lamp examination shows increased chamber cells and keratic precipitates. So given the most likely diagnosis, what is the initial treatment? So is it steroid eye drops? Do we increase her methotrexate dose? Do we give oral steroids? Do we give monoclonal antibody treatment? Or do we give oral acyclovir?
So we've got mostly A's, 66%, and then a couple B's and C's as well.
Okay, good stuff. So most of you are correct. So it'd be steroid eye drops. So obviously this is an MSK related talk. So we all have an ophthalmology talk later, but obviously when it comes to red eye and MSK, there's not too many different things it could be. And quite often questions now, they're becoming a bit more tricky, and we're getting these sort of two-step questions where it's not just enough to know the diagnosis, but then how to treat it, or the imaging, what imaging to do, like in the previous question. So yeah, when it comes to MSK related red eye, the big one to be aware of, the one that is considered a medical emergency, is anterior uveitis. You may also see it being called iritis. So it's essentially inflammation of the anterior portion of the uvea, hence the uveitis, which forms the iris, hence iritis, and also the ciliary body. And your sort of main symptoms to look up in the question stem is a very sudden onset. Hence, in this question, this lady had it when she woke up. A painful red eye, a very painful red eye, severe photophobia. Quite often, the eye will be tearing as well, and the patient or the person will often have very blurred vision. Now, it is associated with this HLA-B27, which I'm sure everyone's heard enough of at the moment. So your rheumatoid, your ankylosing spondylitis. So people who have these conditions are more predisposed to developing uveitis. Things like most people have it only in one eye. Most people, it happens to sort of young adults. That's when it will first appear. And yes, as most of you have said, you'd give steroid eye drops, so something like dexamethasone, and cycloplegics like atropine, cyclopentolate, which dilate the pupil and help relieve some of the symptoms. If repeated steroid courses don't work, they can do things like injections and things like that, but usually a very rigorous steroid regime where you'd have drops sort of every hour for a week, every other hour for a week, 6 drops a day for a week, 5, 4, 3, 2, 1 usually is enough. So very quickly, because I know this is MSK related, so just so you can appreciate where the inflammation is, the iris of the ciliary and the ciliary body in front of the lens here. And when you examine someone's eyes, this is typically what you'd see. So you've got the red eye, this circumferential redness, the ciliary flush, inflammatory cells, which you'll see on slit lamp, and something called your adhesion, your keratotic precipitates between the lens and the pupil, which, as you can see here, distort this normally nice circular pupil that you have here. So you can see it's sort of distorted here. So that's anterior uveitis, very important medical emergency, but also very easy to identify, especially in questions, and very easy to manage, so an important one. So next question, a bit more tricky. 45-year-old has been admitted after he's knocked off his bike. His ankle is grossly deformed. He's got bilateral malleolar tenderness with severe ankle swelling, and he's got tenting of the medial soft tissues. So what's the most appropriate initial management? So is it application of compression dressing and physiotherapy? Is it application of an external fixation device? Is it immediate reduction and application of a back slab? Is it surgical fixation? Or do we apply a full leg plaster cast?
So it looks like most people are putting C.
Okay. Yeah, good stuff. Yeah, those switched on with your TNO stuff. So what we've got here, it's important to identify, is an unstable ankle injury. So the ultimate treatment is surgical fixation, but what we're concerned about is the initial management. So anytime you have a displaced fracture, you first want to reduce the fracture to prevent soft tissue injuries and help reduce the swelling before you then go into surgical fixation. So as a general rule of thumb, that's what you want to do for your unstable fractures. Now, this sort of question is supposed to cover trauma, and of course, trauma is a very big subject. We could have our own sort of session on trauma, but I just wanted to go through what I think would be some of the common things that would come up in sort of finals, UK MLA stuff. So another sort of result of a traumatic injury are your neurovascular injuries. Of course, they cover a wide range of conditions, but you want to, they're high risk in patients who have limb fractures, long limb fractures, who've had trauma or surgery to the limbs, people in casts, splints, constrictive dressings, crush injuries, gunshot wounds, and the 5 sort of P's of neurovascular assessment. And if someone has one of these, then you want to suspect if there's neurovascular compromises, painful limb paralysis, paresthesia, so reduced sensation, pulselessness, and pallor. So those would be your indications of someone having a neurovascular compromise. And then generally speaking, principles of fracture management: reduce, hold, and rehabilitate. So anyone sort of has a fracture and you're asked about the management, you want to reduce the fracture, as mentioned in the question. You want to hold it in place. Usually this is through, or if open reduction, internal fixation. In other words, plates and screws. And then you want to rehabilitate. things you want to be wary of when it comes to managing a patient is, are they diabetic? Do they smoke? These all affect bone healing, wound healing, things like that. So mobilize the fracture, including the proximal and distal joints. Check neurovascular status as previously mentioned, especially after you reduce the fracture and you hold the affected limb in place. Analgesia, 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 the most important medication as an orthopod. Manage the infection as well, give tetanus if required as well. If there's open injuries, that's when you'd also want to introduce your IV broad spectrum antibiotics, and you may need to do some wound debridements as well. So yeah, your open fractures, they're an emergency. They need to be debrided and lavaged within 6 hours of injury. So when it comes to sort of trauma management, we've covered what you do if someone's got a displaced fracture. We've covered what you do if someone has an open fracture. And we've got, with regards to more so ischis, OSCEs, if someone presents with a fracture, how you would manage them generally, reduce, hold, rehabilitate, surgical intervention, replace and screws, open reduction, internal fixation, make sure they're not, check if they're diabetic or if they're a smoker, make sure they've got pain relief, make sure there's adequate rehabilitation after. So those key points, you can't really go wrong. And then very quickly, just wanted to go over some general fractures, which you may have come across in sort of revision, past med and all that stuff, and can very well come up. So we talked briefly about Perth's disease, avascular necrosis of the femoral head, and we mentioned that scaphoid fractures are also another risk of that. I'm sure everyone's heard of Fouche fall on an outstretched hand. So often requires multiple views. Again, going back to the previous question, so orthopedics is very much the same principles across the board. So again, most of the blood supply from the scaphoid is from the dorsal carpal branch, which is a branch of the radial artery, and it's this retrograde blood supply. So once this is cut off, there is no sort of dual blood supply to the bone. So if that's cut off, then you risk avascular necrosis. You've got your Colles fracture, which is your dorsally displaced distal radius, or your dinner fork deformity. And hopefully here you can appreciate the shape of the hand and the shape of the dinner fork. And again, surprise, surprise, open reduction internal fixation with plates and screws is how you would manage that. And then on the opposite side, you've got Smith's fracture, which is a distal radius fracture, but it's less common than a Colles fracture. But it's when you've got a volar fracture. So volar being the palm side, dorsal being the back of the hand. So Colles is dorsal and Smith's is palmar. You've got Monteggia and Galeazzi fractures. So your Monteggia fractures are your proximal ulnar fractures, and your Galeazzi is your distal radial fractures. And again, unstable injuries, or if again, you've got clavicular fractures. Most commonly your medial 2/3, distal 1/3, and that's because that's the thinnest part of the bone. No attachment to musculature or ligaments. And again, principles of treatment, particularly in an unstable fracture, which you've got here, plates and screws. And then very obviously here, you don't forget your dislocations. So hopefully it's quite easy to gauge that this is a dislocated shoulder here. So that's a very quick whistle-stop tour of your common fractures. There's a few other like Potts fractures of the ankles, boxer fractures, which is your fracture of the little finger, particularly when people are drunk and they get into a fight and they try to punch someone and they come in with a painful little finger. So question 9. So 45-year-old lady visits a GP with a 2-month history of pain in her arms, shoulders, neck and back. She reports headaches, fatigue throughout the day. So routine bloods, including a thyroid function, rheumatoid factor, ESR, are all normal. So what's the most likely diagnosis? And hopefully this is a bit more of an easy one.
So we've got mostly A's.
Yeah, good stuff. So fibromyalgia is part of the UK MLA sort of MSK content map. So just a quick word on fibromyalgia, because hopefully it's fairly a more sort of simple one. So it's often diagnosis of exclusion. So you give a diagnosis of fibromyalgia once everything else has been ruled out. So you've got essentially widespread pain, fatigue, lethargy at specific anatomical sites. Usually it's like the shoulder girdle, the hips as well, and the knees. It can get mixed up with sort of menopausal symptoms, this idea of brain fog as well, but you don't usually get the sort of the mood swings. And typically fibromyalgia can present in women who are a lot younger. The exact cause is unknown, but treatment, it's mostly conservative. Aerobic exercise, strongest evidence base, CBT, and again, medication to manage the pain. So I'll keep that one brief, but hopefully that's just a quick and concise note on fibromyalgia. So my last question. A 60-year-old male is admitted to the emergency room with a fall. So on examination, there's right hip tenderness on movement in all directions. Hip x-ray confirms an intratrochanteric fracture. So what's the best management option? And we've got total hip, splint in a back slab, hemiarthroplasty, steroid injection, or a dynamic hip screw.
So I think we're very much split between A and E.
Fine. So in this case, for an intratrochanteric fracture, the answer is E, a dynamic hip screw. So I can almost guarantee that everyone's had a question on a hip fracture, and I put my money on if there's any orthopedic related question you'll get asked, it would be a hip fracture and how to manage it. And it sometimes can be very confusing, but with most things, it just comes down to where the fracture is and being familiar with your anatomy and the words associated relative to where in the hip, where on the femur the fracture is. So first, general principles, identifying a fractured neck or femur. You've got a shortened and externally rotated leg. You've got groin pain, hip pain, being completely unable to wait there. Pain on palpation. A common test is being unable to straight leg raise without there being a lot of pain. One thing that's very important to assess the nature of the fall. So if it's a low impact versus high impact fall, and that can influence management as well. So just as a general sort of look at the hip joint. So your head, your neck, your greater trochanter and your lesser trochanter. You've got your pubic symphysis here and your ischium here. Now, again, not a lot of hip fractures are very obvious. So on radiology, again, there's certain things that you can use as a clue as to what causes a hip fracture. One thing in a hip fracture is because you've got a shortened and externally rotated leg, and hopefully you can appreciate on this x-ray, is in a hip fracture, we can see the lesser trochanter a lot more in a fractured hip than we can in a less fractured hip. And hopefully if you think about the leg being externally rotated, you can appreciate that this will expose the lesser trochanter more. So the staging for a hip fracture is often the garden fracture. So we've got garden stage 1, which is a sort of undisplaced hip fracture, but only a partial fracture of the femoral neck. Your garden 2 is a still undisplaced fracture, but we've got a complete fracture of the femoral neck. Garden 3 is when you've got partial displacement, and garden 4 is when it's completely fallen off. And I guess out of everything, if you want to know what you do in what cases, it's just learn this diagram. This is probably the best diagram that I found with regards to your anatomy and what you would do for certain fractures. So you've got your hip joint here, your femoral head, and what you've got, this line here between the greater and the lesser trochanter, basically determines whether you're intracapsular, so within the capsule of the hip joint, or extracapsular, outside the capsule of the hip joint. And then when you've got your intercapsular and your extracapsular, you can split that further. So you've got your intracapsular fracture, which can either be undisplaced or displaced. So you've got 2 different types of fractures there. Then you've got an intratrochanteric fracture. Here you've got a subtrochanteric fracture, sub meaning underneath the trochanter. So greater trochanter, less trochanters, your fracture within the trochanters, or an intratrochanteric fracture, which is where the questions, which was in the question stem, and then you've got a subtrochanteric fracture underneath the trochanters. So those are your sort of 3 regions. A fracture, you can get a fracture here, and 2 types of fracture here, displaced or undisplaced. So your 4 fractures, and you'd all manage them differently. Just a quick word again, going back to radiology. Again, fractures aren't always that obvious. So as well as the lesser trochanters being more unclear, you've got this sort of imaginary anatomical line called Shenton's line. Now, this is a line that's drawn between the inferior border, so the lower border of the superior pubic ramus. So you've got pubic rami here, superior, inferior. So the inferior border of the superior pubic ramus, and it goes along the obturator foramen, this hole here, the inferior medial border, so inferior underneath medial on the inside of the body, so the inside border of the neck of femur. And what you've got in a fracture, hopefully you can see here, is you've got loss of Shenton's line, so this loss of this continuity from the inferior border of the superior pubic ramus and the inferior medial border of the neck of femur. And you've got, again, a very prominent lesser trochanter. So, surgery is the gold standard treatment. So let's go through it one by one. So if you've got an intracapsular fracture, so a fracture here, right on the neck of the femur, if it's an undisplaced fracture, you'd use internal fixation. Now, if it's a displaced fracture, a more severe fracture, a less stable fracture, you would either do hemiarthroplasty or total hip. So arthroplasty is just where you replace the head of the femur or the ball, and the total hip is also when you replace the surface of the pelvis, so the socket. So arthroplasty is just your ball, and your total hip will be the ball and socket replacement. Whether you do one or the other, from my understanding, depends on the age and the mobility of the patient. So if you've got an elderly person that doesn't move, better to do an arthroplasty. Less invasive, better recovery. If you've got a younger person who's a lot more mobile, then do a total hip. That's the general rule of thumb. Then we've got your extracapsular fractures. So moving down here now. So whether you've got usually if you have an intratrochanteric fracture, you do dynamic hip screw. If it's subtrochanteric, you do an IM nail. And then some points for further management when we talk about fracture management. When we come to the rehabilitate section, we want to allow weight bearing immediately post-surgery. And again, we want to look at long-term treatment. Typically, hip fractures happen in elderly people. So your FAC scores, your falls assessments, osteoporosis, bone protection, and cover if they need it. So very quickly on fracture healing, as a general rule of thumb, so your first week is your inflammatory process, your formation of the hematoma and your inflammatory exudates. Week 2 and 3 is where you get your formation of a callus and your softer bone forming, and that develops to your union phase. So this is where you get the actual mending of the fracture and the two ends of the bone sort of joined together. So you've got a sort of a stable fracture, but a fracture which is still weak. You've got consolidation 2 weeks after that. So you've got this sort of soft, spongy bone, which is replaced by the lamellar bone, the harder bone. And then 2 years after the fracture, you'll still get continual remodeling. So your bone absorption by your osteoblasts, your bone absorbed by your osteoclasts and your bone deposition by your osteoblasts. And so these are different types. So this is your dynamic hip screw. So going back to the question, so plate and screws, and what you've got here is something called a lag screw here and a compression screw here. So as the name suggests, you get compression of the bone, brings the sort of two ends of the bone between the fracture together, which helps promote healing. So that's the sort of principle of that. And then you've got your hemiarthroplasty, which is just the ball of the ball and socket joint that's being replaced. And then you've got your total hip replacement, which you do in your younger, more mobile population, which is your ball and your socket replaced. So hopefully that's cleared up your hip fractures.
We just had a quick question, Harry, if that's okay. Someone's just asked, when do we use internal fixation with DHS versus internal fixation with IM nail?
So paper suggests that internal fixation an IM nail is less invasive, promotes better healing. From what I've seen, an IM nail is typically done for subtrochanteric fractures, whereas trochanteric fractures is a DHS. So that's what I've seen myself.
That's what I've seen as well.
So, and I don't know if you want to go back and do your question or not.
We've kind of, I don't know, we can do, I'm conscious we've kind of run over. I'll send, so the feedback is available for you to complete now. I'm going to just link to our social media as well. I'm happy to go over the question that we missed, but you also feel free to go. I can talk through it anyway because they'll all be recorded as well. But please, yeah, go ahead.
If I could just say as well, I'm sure you've heard me go on about it, but we are doing some research as well, particularly with those of you that are doing your UK MLA at the moment. Hold on, let me just end the show very quickly. So yeah, we're doing research here, particularly those of you who are doing the UK MLA or have done it. So we'd be very interested if you could help us out with some research. And also if you would there's a form there to fill in, which basically is your views on how research has been delivered by your university, how many hours of study they've allowed, and what you've done in an independent study. Now, I appreciate some of you might be interested in a career in medicine, surgery, whatever. Research is becoming more and more of a thing. So if you are interested, this next doc that I've pasted is if you want to help get involved with research. So I know for surgical training that collaborative authorship is something that's becoming actually scoring points. So if any of you are interested in research collaborative authorship, you can fill in that form and I'll basically drop you a message in a few weeks' time, and all that we ask is that you distribute that questionnaire to your peers. We haven't decided on the final number, but you get sort of 15, 20 responses, not a whole lot, and then we can give you collaborative authorship on it. Hopefully papers and presentations that we're hoping to do in the future. But yeah, the whole sort of theme of that is just seeing what student perception of the UK MLA is, how confident they feel, how much support they've been given from universities, and how they've sort of been revising themselves. So if you're interested, that's there. It'd help us out a lot. So feel free to. Okay. Shall I reshare and then do you want to do your?
Yeah, sure.
Yeah.
And just let us know if you prefer this sort of format where we do question and answer rather than all the questions and all the answers. That would be really helpful too. So we'll just go quickly back to question 5. I know someone's asked, could we show the first 5 slides, please? But the recording will be available on Medal, so you can go back and take that in your own time as well. Go through them in your own time. So we've got a 28-year-old female presenting to A&E with a suspected right ankle fracture. She was out at a dinner where she was wearing heels and she tripped and fell, causing immediate pain and an inability to weight bear on her right ankle. An X-ray of her ankle shows an oblique fracture of the distal fibula at the level of the syndesmosis with no widening of the distal tibia fibular articulation. What is the likely direction of force on the foot that has resulted in this injury? I kind of alluded to the fact this is a very difficult question, but I am happy to just still go through it. They would be very mean to ask you this question, but it's still quite interesting to know about. I'll give you a couple minutes, whoever's left. No worries, Alicia. Thank you. Cool. So we're very much split on all of the. I think we've got one for every letter. There's absolutely no way I would have got this. The only reason I know about this is because I'm currently doing a trauma and orthopedics rotation. So it is actually, next slide, supination and external rotation. If, Harry, can you go a few slides down? I think it's the one that says Weber. Yeah, just continue going. So this is explaining the mechanism of the injury, but I will actually want to start with this slide. So I don't know if you've ever heard of the Weber classification of ankle fractures, which is how it's usually classified, as in the most common, most sort of famous one that we talk about. So we've got Weber A, Weber B, and Weber C classification of ankle fractures, and that really refers to whether the fracture is at the level of the syndesmosis, below or above the level of the syndesmosis. And the syndesmosis is the fibrous tissue that joins the tibia and the fibula together. So if it's below the syndesmosis, that is a Weber A fracture. So you can see that little band running, joining the fibula and the tibia together, that's syndesmosis, and the fracture has just occurred below that. And Weber A fractures are usually quite stable fractures, so they can be treated sort of conservatively with an application of CAS. Whereas Weber B and C, which are at the level of syndesmosis and above the levels of the syndesmosis respectively, are often unstable fractures that do need to be treated with either internal or external fixation. The other way to classify these injuries, which is what the question is alluding to, is using the Log-Hansen classification. So there's a very specific sort of mechanism of action that results in these fractures. So in this case, it would be supination and exorotation or external rotation injury that's caused this fracture. I've got the question here actually. Let me just pull it up. So she was out at the dinner where she was wearing heels, where she tripped and fell, causing immediate pain. So she's wearing heels. So if we go to the next slide,
That one.
Yeah, that one. Sorry, I should have just put them in the right order. That would have been helpful. So this is just demonstrating supination and external-rotation. So you can imagine she's just rolled onto the outer edge or the lateral edge of her ankle, her foot. That's the supination, and external-rotation going through externally rotating the foot as well. It's difficult to demonstrate on camera, but I feel like this picture demonstrates it nicely. So what's first going to happen, next slide, is there's going to be stress put through that tibiofibular ligament, the syndesmosis, causing a fracture through the distal fibula. So that's step one. Next. And if it continues to externally rotate, we can see that this posterior malleolus of the tibia, that's going to fracture as well. So we're going sort of in, if you can imagine, like a clockwise direction around the foot. So we're starting laterally, then we're going posteriorly. So the next would be medial. So next slide. That's the medial side of the tibia, the medial malleolus, an avulsion fracture. So that means the ligaments tore in that piece of the bone away, causing an avulsion fracture. So those are the 4 stages of a Weber B fracture or supination external-rotation fracture, which is really complicated, but I thought it's quite interesting actually once you break it down to how exactly the injury causes each stage of the fracture. And it depends just how much of a high energy force it is. Obviously, the more it progresses around that, circle from lateral, posterior, and medial, the more unstable the fracture and the more that you would need sort of early intervention. Next slide. And yeah, so this just covers the other mechanisms of injuries for Weber A and Weber C fractures as well, but I won't get into that since it's very late, and I appreciate all of you joining us this Thursday. This is just an X-ray of the image that's what we're talking about. So we've got a fracture of the distal fibula and at the level of the syndesmosis. There can be a widening. We said there wasn't a widening between the tibia and fibula, but there can be present. We can see the slight line that the red arrow is pointing towards, and that represents a fracture of the posterior malleolus. And we can see sort of soft tissue swelling where the yellow arrow is pointing, suggesting there could be injury to the medial collateral ligament as well. So it could potentially be a stage 3 or stage 4 fracture, Weber B fracture. All right, that's everything, guys. Thanks again for taking the time to join us this Thursday evening. Do we know what's on next week? Let me just pull it up. So we're running this series every Thursday at 7 p.m. The next one is PEDS. So we've got the next 2 weeks will be on PEDS. So we would love to see you again. And we'd also love if you could fill out those forms for us as well. All right. Thanks so much, everyone. Thank you.
Take care. Bye.
Bye.